So moving on with the interventional echo. So this is something related to PCI, which is quite common. And then I'll be looking at how we should do the echo. What is the status of echo pre, peri, and post? So first and foremost is pre-PCI. So broadly, you can have these two scenarios. So you can have an emergent scenario, you can have an elective scenario. In terms of emergent, it will be an ACS or a STEMI, and you'll be doing the ECG blood test, an IV line, treatment will be started, and then patient can either be stable or unstable. And the PCI is being planned. And at this point of time, echo is given a low priority, but it is very important to remember that it can cause a problem later on. So in this hurry, it has been repeatedly shown that if it is missed, there are other findings missed at this stage will create problems later on. When it comes to elective, it is already diagnosed to have a CAD, it is more of a CAG being done and what the PCI is going to be, or a CAG done and lesion is established, and then what PCI is going to be done. And here echo is more likely to be done. Now, what are the types of echoes? You have this conventional echo, and then you have the advanced echo. When it comes to the emergent PCI, without any sort of hesitation, one can say that it is primarily the focus is on conventional echo, just 2D and color, and the other modalities are less likely to be used or not to be used. Contrast has a very limited role. I'll come to that later. Now, when the patient is stable, so the approach is to look at LV function, looking at the RWMA and any masses, especially the thrombus and any other associated conditions. So you have a clear sort of a picture as to what is happening to the LV and in terms of any other problems. When the patient is unstable, then in addition to whatever you are going to look at this in terms of this list, you're also going to look at mechanical complications. So mechanical complications has already been elaborated by Dr. Aniruddha. And typically your focus will be on the ventricular septal rupture, and you will have to go for sort of off-axis views because these are not easy sort of findings many a times. So you have to be careful not missing them. And also papillary muscle rupture. So this again, when you see an eccentric jet, an MR, and you have to take a closer look at the papillary muscle. Now, after this, there is right ventricular MI, especially in the setting of inferior wall MIs. You'll be looking very closely at the right ventricular wall, especially if it is going to be a proximal RCA. And this again can be a challenge in terms of fluid. And then, the inotropes also, you should be careful in using it. So this is another important finding. Now, when we are looking at elective is something where you have time and you are sort of, you can sort of go through the other modalities. So you can have speckle, you can do a 3D also, and you can do contrast also. So again, the primary focus is looking at LV function. And just a brief sort of mention about diastolic dysfunction. Also pay a close look at the diastolic dysfunction. More severe the diastolic dysfunction, more stormy the course is going to be for the patient, especially more severe in terms of failure. And you have to be very sort of careful in terms of fluid management later. Then the other important thing is to look at the number of segments involved, and you're also coming to, going to look at whether it is the distal lesion or whether it is proximal lesions. And then also when the window is not good, now you have the luxury of the time of looking at the LV a little more carefully. So if you do have this luxury of looking at contrast, push the contrast, look at the wall motion a little more carefully, and look at the LV function, and then also for any clots and any other abnormalities. Then also, you can have a sort of a rough look, may not be accurate, but at least you will have a fair idea. If the thickness is preserved, that is more likely to be a viable myocardium, and that the PCI may benefit. And if you see a scar over there, and if, for example, here there's a lot of scarring in the LAD territory, the LAD PCI is not going to help here. So this is what the interventionist would benefit from, saying that there's a scar and thinning. Now, viable territory again, it's like a poor man's sort of viable test. So looking at low dose dobutamine, and this can be done in certain scenarios. So, for example, those who cannot undergo MRI, that would be the preferred one, or any other the perfusion scans. So those are the other priority ones. But when it is not possible, you can look at low dose dobutamine, and also look at the MR. So the MR is, you're trying to find out what is the reason due to MR. So especially in the presence of posterior wall, inferior wall involvement, it is, you know that it is an ischemic MR, it's a tethered MR, it is going to be an eccentric jet, posterolateral jet. And also you're trying to find out what is the quantification. You may want to check later whether it is increasing or decreasing. Now on table, so now you are inside the cath lab, the PCI is going to happen, and or it will be sort of being performed. So what is the role of echo here? Now, one has to look at the vulnerable population, or the, the people who are most likely to give problems: advanced stage, diabetics, chronic kidney disease, acute coronary syndrome, patients in heart failure, multivessel disease. These are the people who will have more complications. So these are examples of pericardial effusion. This is the most feared complication as far as PCI is concerned. So you can see that the top one, there was mild pericardial effusion, there was a coronary perforation. There was a immediate pericardicentesis was done, patient improved. The one below was the rapid sort of accumulation, and then patient went into tamponade. And the other one, the last one, shows a pericardial effusion which happened after PCI. Now, so what are the things that you should be aware of as far as the cath lab is concerned? So you should, typically, any cath lab would have it, but it's just to re-emphasize how it is important to keep these things ready. One is having the pericardicentesis tray, and then again, you need not be in the lab all the time. So, but you should be available. So there should be some sort of a protocol where quickly the echo machine and the person who's going to do the echo should be available. So this is just an algorithm which has been given in one of the publications in circulation. Now, what are the scenarios? What can go wrong? So one is coronary perforation. So this is again with stiff wires or dilating the balloon, or if it is going to be oversized stenting, or any problems with the arterial wall. So this can happen. And again, pericardicentesis here. So this is where echo can help. And main vessel coronary perforation. So you have the big vessels, the main proximal one. So again, the algorithm here, simple algorithm, we all know about it, but nothing wrong to going through it again. So keep on doing serial echoes where there's a suspicion that there's a perforation that has happened, and if necessary, do a synthesis and keep checking. And then if the perforation is quite bad, there is a classification for that also. If there is Ellis type 2, 3, so there's that it is going to be a major one, tamponade is going to happen. And then use of contrast. So to find out whether if you push it into the coronary and if it goes into the pericardial space, you know that the leak is still happening. So this can be helpful. So this is where contrast can be helpful. Next, distal vessel, more or less the same algorithm. You're going to go through it, and a similar sort of an approach will be for the distal vessel also. CTO perforations. So again, pericardicentesis. So there's a lot of sort of improvement in terms of the technique. So there's more sort of focus on the CTOs in terms of how the rota is used. So here, what are the problems that can happen? So during the rota, the coronary dissection can happen, perforation can happen, and again, similar complications, in terms of pericardial effusion. So these are the incidences in terms of the perforation. So anywhere, less than 5%. Myocardial infarction can happen. So these are the two sort of big ones which one can try and find out in terms of echo. Abrupt vessel closure. So again, looking at the RWMA, whether it is improved, worsened, more segments involved. LV function, looking at MR. So this is where sudden closure. Now, sort of putting everything into perspective. So if there is an acute drop in BP, if there's a hemodynamic collapse, so what is the sort of, what does echo do? So you have the interventions on one side, they have their own approaches, but what can you, with an echo machine, what can you do? So one can look at it's a very rare one in terms of an iatrogenic aortic regurgitation that can happen when sort of they can do some, something to the aortic valve. So this has to be kept in mind. And also to look at any acute MR which has worsened, and also looking at the LV function. And again, it is going to be the tamponade, the pericardial effusion that should be looked into. So these are sort of quick points in terms of when there is a drop in BP, and from echo, this is where the contribution can happen. So this is sort of a picture which sort of sums up what all complications can happen and how echo can help. So this will be the abrupt vessel closure and then the coronary artery perforation. So quickly, I'll run through the post-PCI, the last few slides. So LV function itself, again, you can see that how quickly the myocardium improves. So you have a patient who underwent a PCI for LAD, and again, you can see the recovery that has happened. And also look at the diastolic function, how the patient has improved, but still continues to be from grade 3 patients, still in grade 2. So these patients don't do well. They'll keep coming repeatedly. And this can be alert to the clinician to say that these patients might come back with failure, more admissions and problems. So pre-discharge, as far as post-PCI is concerned, you're going to look at the improvement, worsening of any MR, pericardial effusion, what is happening, you're monitoring it, any new sort of happenings in terms of pericardial effusion, and then status of acute AR, again, very rare, but it can happen. And one of the few things that are now we are seeing a little more in terms of infections. So there is infection in terms of an abscess, infection in terms of pericarditis, aneurysm. So these can happen. Then speckle echo, limited use, but it is available. If it works, use it, but don't overread it. It can be a problem sometimes because it's still not very reliable when it comes to segmental interpretation. Contrast echo, as I mentioned, can be used. Perfusion, if it helps, you can try it. So it's got sort of its own learning curve. And then 3D LVEF also to some extent can be helpful in terms of serial monitoring, especially patients with heart failure. You want to know what's happening to their status. So to conclude, echo is an invaluable tool in all phases of PCI. And once in a while, you might want to consider TE in some situations. So these are the various scenarios. And then transthoracic echoes definitely can be helpful. And the complications more in complex PCIs and CTOs. And early recognition is what echo can be really sort of helpful, and it's invaluable. Thank you.